Good afternoon and good morning to those to the west of me. Welcome back to day 2 of the National Maternal Health Innovation Symposium. I am Allison Northrup, Associate Director for Public Policy and Government Affairs at the Association of Maternal and Child Health Programs, known as AMCHIP. I have the honor of introducing our next plenary panel, Leveraging Policy to Achieve Maternal Health Equity. Before I do so, I'll take just a minute to introduce you to the organization that I represent. AMCHIP is a national resource partner and advocate for state public health leaders and others working to improve the health of women, children, youth, and families, including those with special healthcare needs. We envision a nation that values and invests in the health and well-being of all women, children, youth, families, and communities so that they may thrive. And we are working to center equity in all that we do. Last year, AMCHIP issued a public commitment to undoing racism and acknowledged that racism is the most significant contributor to racial inequities and maternal and infant health outcomes. We are proud to reaffirm this commitment through a joint organizational statement with other maternal and child health colleagues earlier this year. AMCHIP's commitment set out foundational principles. One of those principles is that the solutions to inequities in maternal and infant health outcomes already exist in the communities experiencing those inequities. It is on public health organizations like AMCHIP to embrace the organizations and individuals from these communities as the thought leaders they are and to whom we should be holding ourselves accountable. The commitment also set out actions AMCHIP will take to bring about meaningful change within our organization and in our external work towards undoing systemic racism. It's important to us at AMCHIP that we as an organization not only take a public stance about undoing racism, but that our actions reflect these words. We know that we have much to learn and that we may not get it right on the first attempts, but we are committed to taking the necessary actions for change. AMCHIP is proud to partner with the Maternal Health Learning and Innovation Center in its work and values the center's explicit focus on advancing equitable maternal health outcomes. And I am very excited to have the opportunity to introduce this afternoon's plenary panel, Leveraging Policy to Achieve Maternal Health Equity. Our 3 panelists are leaders in equitable maternal health policy at both the federal and state levels. Dr. Jamila Taylor is Director of Healthcare Reform and Senior Fellow at the Century Foundation, where she leads TCF's work to build on the Affordable Care Act and develop the next generation of health reform to achieve high quality, affordable, and universal coverage in America. Throughout her 20-plus year career, Dr. Taylor has championed the health and rights of women of color and other marginalized communities, both in the US and around the world, promoting policies that ensure access to reproductive and maternal health care. Breana Lipscomb is the Senior Manager of the U.S. Maternal Health and Rights Initiative for the Center for Reproductive Rights. She has over 15 years of public health experience and has worked in Tennessee, Guatemala, and the state departments of health in both Iowa and South Carolina. In her current role, Breana develops advocacy strategies to promote Black maternal health, particularly in the South, by mobilizing a broad base of stakeholders to advance state-level policies that further reproductive rights as human rights. Kichelle Webster is Director of Financial Services and Healthcare Policy for Stewart Strategies and Solutions. Kichelle has over a decade of public policy and political strategy experience working in the U.S. Senate, the U.S. House of Representatives, and on presidential campaigns. During her time in the U.S. House of Representatives, Kichelle served as Senior Policy Advisor for Congresswoman Alma Adams. And in that role, Kichelle spearheaded the launch of the historic bipartisan Congressional Caucus on Black Maternal Health. I will also note from Kichelle's bio that she is a proud native of the U.S. Virgin Islands. I'm going to kick off the panel by asking Jamila the first question and then let our panelists take it away. I'll rejoin the panel during the Q&A portion to ask our panelists questions from the audience. If you have a question that you'd like to pose to the plenary panelists, please go to the Day 2 Q&A tab and find the title of this plenary. Let's get started. So this first question is for Jamila. Okay, Jamila, medical racism. It is a well-documented thing that has been occurring for centuries. Can you speak to the historical foundations of reproductive oppression in the United States and what the implications are for the vast racial disparities we see in maternal mortality and morbidity today?
Great. Thank you, Allison. It is such a pleasure to be here, and most importantly, on this esteemed panel with two women that I admire greatly working in the maternal health equity space. So medical racism is something that we talk about in the context of maternal health because it's so important for us to get a grasp on it in order to understand the implications for maternal mortality and morbidity we see today. J. Marion Sims, who some may know as the father of gynecology, experimented on Black enslaved women's bodies to advance the study of obstetrics and gynecology. This was often without anesthesia, and other slaves would even be ordered to hold these women down during these forced surgeries. Some women came out of these situations fertile, infertile, with fistulas, and disabilities, lifelong disabilities due to surgeries gone wrong. Fast forward, and then we also began to see the institutionalization of forced sterilization, particularly for Black, Native, and Puerto Rican women. This would come to feed the entire eugenics movement to the point where medical protocols and even legislation was introduced to further institutionalize this harmful practice. Between 1905 and 1922, we even saw 18 states pass a total of 30 bills authorizing involuntary sterilization. And unfortunately, we still see this practice today. The abuse and neglect of Black and Native and Puerto Rican women is well documented, as Allison mentioned, throughout American history. Ignoring Black women's pain is grounded in racist stereotypes dating back to slavery, from which I mentioned, and the perception that Black people have a higher threshold for pain. We continue to see this common thread even today. And when I say that, I mean the ignoring of Black women's pain. We see this in countless stories of maternal death and morbidity, the stories of Shalon Irving, the CDC researcher, Kara Johnson, the licensed pilot who spoke 5 languages, all dying of preventable maternal causes, and the stories of so many others. This is why it's critically important for us to think about how we approach this issue in the context of a human rights and reproductive justice framework. Breana, as folks explore opportunities to change existing maternal health policies or perhaps create new ones, what value is there in grounding these policies in human rights, reproductive justice, and birth justice frameworks?
Thank you for that question, Dr. Taylor, and thank you all just for the invitation to be part of this panel discussion. Dr. Taylor, I really appreciate the foundation that you laid, really explaining the history of reproductive oppression, particularly for Black communities, but also Brown communities in the United States, because I think that informs or supports why rooting maternal health policies and programs in a human rights, reproductive justice, and even birth justice framework is really important. So all of these frameworks assure that the needs of individuals and communities most impacted by an issue are centered in the solutions. And the human rights framework specifically then creates structures for accountability to assure that governments and institutions are putting forth their best effort to uphold the rights and to remedy any human rights harms that occur. So really quickly, I'm going to do my best to speak about all 3 frameworks succinctly. And I'll start with human rights. So when we think about human rights, we think about the right to health, which is the key frames for maternal health policies specifically. And so we call it the triple AQ framework. So this framework requires that healthcare goods and services are provided without discrimination, and that the services be available in sufficient quantity in a specific geographic region, that they be accessible both physically and financially, that they are acceptable medically and culturally appropriate, and that they are of good quality. So that's the triple AQ: available, accessible, acceptable, and of good quality. So also with human rights, we have these core principles, and these principles are really easy guides for shifting maternal health policies. So the principles that we think about in human rights are accountability, transparency, non-discrimination, empowerment, autonomy and self-determination, dignity, and participation of those most impacted by the issue. The human rights framework also is an opportunity for us to recognize that the adverse impacts of discrimination are compounded when individuals experience intersecting forms of discrimination. So on the basis of gender, class, race, etc. You also mentioned reproductive justice. So the term reproductive justice was coined by Black women in 1994. The Sister Song Women of Color Reproductive Justice Collective defines reproductive justice as the human right to maintain personal bodily autonomy. So the right to say yes or no and have that decision respected, the right to not have children and to have access to the resources needed to carry out one's own reproductive decisions. But it's also the right to have children and to create the families we want and to parent our children in safe and healthy environments. And then if you go that next step, you have birth justice. And this is another response to that historical reproductive oppression and mistreatment that you mentioned, Dr. Taylor. So Black Women Birthing Justice is a collective dedicated to transforming birthing experiences for Black women. And they say that birth justice exists when women and trans folks are empowered during pregnancy, labor, childbirth, and postpartum to make healthy decisions both for themselves and their babies. And so birth justice acknowledges the role of racism, classism, and sexism in negative birth experiences and aims to dismantle those inequalities, especially for women of color, for low-income women, survivors of violence, immigrant women, and for queer and trans folks. The other point I want to make quickly is that the birth justice movement challenges abuse by medical personnel and the overuse of medical interventions. And it advocates for universal access to culturally appropriate, patient-centered care. And like reproductive justice, it includes the human right to choose whether, when, and how to parent, but also where, how, and with whom to birth. So all of these frameworks really build on one another, and they prioritize principles of autonomy, community participation and inclusion, non-discrimination, and accountability. And I want you all to remember some of those principles because I think you'll see some of those themes throughout our discussion today. And so I'm really glad you asked me this question because I think that there's been a lot of action, really a call to action by maternal health advocates, specifically Black maternal health advocates, to integrate these core principles of human rights, reproductive justice and birth justice into maternal health policy. And that leads me to the question that I have for the two of you. So on the federal level, particularly in Congress, we've seen this increased focus and emphasis on maternal health policy that centers Black women and historically marginalized populations. Kichelle, maybe we can start with you, but Dr. Taylor, feel free to jump in. Can you all talk about the creation of the Black Maternal Health Caucus and the efforts of Congresswomen Alma Adams and Lauren Underwood to make this issue a priority in Congress?
Absolutely, Breana. And, I just want to echo, both of you in saying that it's such an honor and a privilege to be sitting on this panel with both of you, good friends, and sister warriors in this work. And so this is a story that I love to share, one that is, I guess, near and dear to my heart. When I first joined Congresswoman Adams' team in 2018, she had just finished introducing the first ever Black Maternal Health Week resolution with Senator Kamala Harris. And the office had been approached actually by the Black Mamas Matter Alliance, this really powerful organization that is Black women led, that was really doing that work that you talked about, Breana, about centering Black women at the core of the maternal health policy agenda and the kind of helping to chart the direction that we really needed to go in terms of advancing, quality care, accountability and equity and birth justice for Black women and trans folks as well. And so later that year, I remember talking to the Congresswoman and to the Chief of Staff about, how can we do more? How can we really capitalize on this issue and really make it a priority in Congress? And we thought, well, why not start a congressional caucus? And, caucuses, within Congress can take many forms. Sometimes they're just, a check the box. You just want to maybe indicate you have an interest in an issue. There's caucuses for everything: autism, bone cancer, wine, you name it. But we really wanted to create something that was substantive and that was going to advance real legislative solutions and real quality policy. And so we got the Brain Trust together. I remember we brought Dr. Taylor in from CAP when she was at CAP at the time, Black Mamas Matter Alliance, the Center for Reproductive Rights. I think we had one more organization, maybe the March of Dimes. And, we said, we want to start this caucus. What do you all think? And it was such a resounding absolute yes. This is an issue that we have to really put on the map. And so we went forward from there. In April of 2019, we had our launch, and actually, let me just backtrack. A young member of Congress was recently elected in 2018. It was Congresswoman Lauren Underwood. She was the youngest Black woman to ever be elected to Congress. And, she had a personal background in nursing. And Dr. Shalon Irving was actually a really close friend of hers. And so this is an issue that was very near and dear to her personally, and to Congresswoman Adams as well, whose own daughter had a maternal health scare 15 years ago when she gave birth to her daughter, where she almost lost her life due to physicians not listening to her, which is an issue that you're going to hear from us often. It's a critical part of where that societal and systemic kind of racism intersects with our hospital systems, unfortunately. But we reached out to Congresswoman Underwood and she said, absolutely, let's do this. And so in April of 2019, we launched the caucus. We launched it with 58 founding members. It had such a resonance, I think, across the Congress, even from its early stages. And then from there, we got to work on, pulling the stakeholders together. We held a stakeholder summit to really make sure that, we were pulling in ideas from all across the spectrum. But I think one of the things that was really critical for us was centering the voices of Black women, centering the voices of Black women leaders who unfortunately didn't really have a seat at this table for many years, and so that was a core part of our mission, just ensuring that the caucus aligned its priorities with the women, with the birthing persons who were most marginalized, in this work. And so, from there, we were able to work on developing some legislation, which we'll get more into later, called the Black Maternal Health Momnibus Act. But I would love to kind of kick it over to you, Dr. Taylor. You were such an integral part, and thought leader, I think, for us too, as we were developing the caucus. Would love to kind of hear your thoughts as well on the work that's being done on the federal level, and particularly in Congress.
Sure, absolutely. Well, first off, thank you so much for that beautiful overview, Kichelle. And I will say one of the things that I hope our listeners pull out of what you just stated is the leadership of Black women, both in terms of the advocacy space, the researchers, the birth workers, the families that have been impacted, really pushing this forward. At the same time, our foot soldiers on Capitol Hill, also Black women. So I really want folks to lift lift that up, because I think in this conversation about, sort of where we've come as a movement and an effort, we're here because of Black women. And so really want our listeners and folks that are joining us today to take that away from this conversation. I think we're at a really pivotal moment when it comes to the Momnibus, and I'm not going to share too much on the details because I know Kichelle will get more into that later on in the panel. But I just want to say that, there are currently efforts to think through, how we can get this over the finish line. This is such an important year, a critical year for us when it comes to these issues. We currently have an administration that is supportive of Black maternal health and seeing this country once and for all deal with the vast disparities in maternal mortality and morbidity. And we also have, for the most part, I think a Congress that is supportive. We continue to see some challenges when it comes to getting the full Momnibus over the finish line. And we'll sort of talk through some of that later because it is a package of 12 bills. There are many steps that have to be taken in order to get legislation to pass in any given time. A normal, one bill, we're talking about 12 bills. And in order for us to really do justice to this issue, to the women that are most heavily impacted, we had to develop a comprehensive package of bills that addresses almost every dimension of the Black maternal health crisis, but we really got it as close as we could. And so at this point, we're thinking through, how the Momnibus could fit into the next COVID-19 response package, which is being pushed through Congress through a process known as reconciliation, as well as some other tidbits in there that we're also asking for later in the program. We'll also talk about postpartum coverage extension, as well as some other issues. But that's just a taste of, sort of where we are on this, and we'll get more into the details later in the conversation.
Before we move on, just a quick follow-up, because as you all have mentioned, and like you said, this will be the theme of centering Black women's leadership on this issue. But when I think about it, I think the Black Maternal Health Caucus is now at, 110 members? And it is a bipartisan caucus, which is really impressive. And we know this should be a nonpartisan issue. So let's just say that. And I think we all agree this should be a nonpartisan issue. But we also know that we've had to rely a lot on Black women to lead this issue and put it at the forefront. But I'm curious, what are some of the barriers that remain to reaching policy consensus on these issues? And then how have you all encouraged non-Black members of Congress to support these issues, because I think that there are lessons that can be learned at all levels of government.
Yeah, thank you. That's a really great question. And yes, I think we're just so proud of, I no longer work for Congresswoman Adams, but just so proud of the momentum and I think support that the caucus has gained in 2 short years. Over 100 members is truly a feat. And, I think, when you speak to this issue being nonpartisan, that was something that Congresswoman Adams always emphasized. We all have mothers. We all know, women who, or, birthing persons who are mothers. We have these women and individuals in our lives. And so that's an entry point of relatability, for these members as well. They all have Black women and Black birthing persons in their constituencies, right? And so I think really starting there as sort of a base layer, these are individuals that deserve your care and concern and consideration. And I think from there we layered on, presenting the data. I think that when people hear that, Black women and Native women, are 2 to 3 times as likely, in some communities, even higher than that, are more likely to die from preventable, maternal health, or to die from preventable pregnancy complications. That I think it really shocks people that in the United States, in the richest country, in the world, women are dying at these kinds of just sort of, unacceptable rates. And so I think that sort of gets folks, sort of sitting up in their seats, but I think one of the areas where we start to end up facing, I think, a lack of consensus is around the why and the how. Why are Black women more likely to die? And I think, for us, right, we really have been spending a lot of time educating on systemic and structural racism and just sort of these systems and structures that, sort of exacerbate these racial disparities. But for some members of Congress, they don't, or just policymakers in general, they don't necessarily, that's not the first conclusion they come to. They say, okay, well, this, this mother had a poor diet, or, she wasn't taking care of her body, or, she wasn't going to her prenatal appointments, and so it becomes a blame game towards the individual. And it becomes, well, this isn't an issue that, we can solve through policy. This is an individual responsibility problem, right? And so we spend time now educating around, no, there's a lack of access to quality healthcare. People are uninsured, they're not able to kind of get the quality care that they need. And these are all things that are embedded in a system. And so I think that's kind of one of the areas where we often run into some issues with some members. And members have even, in congressional hearings, they have openly kind of expressed, I think, some of these concerns and have been met with, of course, swift wrath from our communities. But again, I think there is a level of ignorance, and I think, and sometimes, it is unintentional, sometimes it is willful. And then on the flip side, I think another area where we run into some barriers is around cost, and what is the investment that we actually need to make? And so for some of our members who are a bit more fiscally conservative, that, they run into maybe some, I think, concerns around how much, the government will be investing in, sort of this proactive preventative care. And so I think, just broadly, those are some of the issues, but I think for, how we've encouraged a lot of members, particularly, non-Black and those members, I think, really trying to make it relatable as much as we can, and tying in that constituency base has been critical for us. But spending a lot of time educating has been incredibly important. And Dr. Taylor, I don't know if you wanted to add anything else onto that.
No, I don't have anything to add. I mean, I was going to talk about the issue around racism in terms of a barrier and sort of like the understanding and even acknowledgement of the fact that it is a root cause of the poor maternal health outcomes that we see among Black women. And you talked about it beautifully, so nothing to add.
Well, I think this actually kind of allows us to segue a little bit into some of the really wonderful, research work that you've been doing and leading, Dr. Taylor. Last year you partnered with the Commonwealth Fund, to examine the impact of Medicaid coverage loss at 60 days postpartum. And this is a really huge issue, I think that we have been emphasizing, as part of our policy goals, in addressing these disparities. So, would love if you could kind of share with us a little bit more about some of the trends you uncovered in your research, particularly as they pertain to the challenges faced by mothers of color and high-need mothers when trying to access healthcare during that very sensitive postpartum period?
Sure. So first off, just to share, part of our focus on this issue is the fact that, women lose their Medicaid coverage just 60 days after giving birth, which is a travesty. We all know that the care and support that women and families need does not end 60 days after giving birth. And so, a big policy push that we've been going for as a community is to get an extension to at least 1 year. Women of color make up a disproportionate share of Medicaid enrollees. And in this research that the Century Foundation conducted in partnership with the Commonwealth Fund, we interviewed state Medicaid directors, doulas, physicians, state elected officials, and moms whose births were covered by Medicaid in 3 states, Illinois, South Carolina, and New Jersey. We also conducted in-depth policy analysis. And so our research showed that Medicaid loss just 60 days after giving birth can further entrench new mothers into economic hardship. It disrupts continuity of care, which can be particularly harmful for high-need mothers with chronic conditions like diabetes, heart disease, substance use disorders, and mental health challenges. It can also perpetuate inequality among mothers of color. And we've talked a lot about this issue of inequality in the context of both healthcare access and I think broader social determinants of health have even been mentioned. And this coverage loss can also contribute to poor maternal health outcomes. The majority of maternal deaths occur in that year postpartum. And so it's critically important for us to, think through this as a tool in a toolbox. This issue, addressing it appropriately, will take a multifactorial, comprehensive approach. And so we see this postpartum coverage extension under the Medicaid program as an important tool in the toolbox.
That's absolutely critical. And it's certainly, even before the launch of the Black Maternal Health Caucus, one of the members of Congress who's been a huge leader in this space is Congresswoman Robin Kelly, who represents a district in Illinois. And she leads a bill called the Mamas Act, which would do just that in terms of the 1 year postpartum Medicaid extension. So it's a policy that she has been pushing for years, right? I think I want to say at least 4, and now it has become a part of sort of the mainstream as a key kind of core, I think policy proposal and intervention for how we can address and really, I think, kind of tackle the maternal health disparities that we see among Black women. And so policy making takes a long time. It takes some time to build consensus. But I just wanted to kind of emphasize that point as well. But I just wanted to quickly follow up. I think there's been some progress too at both the state and federal levels on extending Medicaid postpartum. Extending Medicaid postpartum coverage. Jamila, can you share a little update on that federal landscape and maybe where we go from here?
Yes, absolutely. And as you said, policy making takes time. We're at a critical moment in terms of both the work on the Momnibus as well as this effort on postpartum coverage extension. So the American Rescue Plan Act, which was the first COVID-19 response / reconciliation bill that was passed in the 117th Congress, includes a state option to extend postpartum Medicaid coverage to 1 year for a limit of 5 years. It does not include any federal matching funds to be allocated to states that decide to take this up. So, this is definitely something for us as advocates to be proud of. We've worked hard to get to this point and really appreciate, I think, both the support of the administration as well as Congress in including this in the bill, but we see it as a first step. we're still working to get this coverage extension mandatory for all states with a generous federal matching. So states have the funding and support they need to do this and to do it right. I also want to mention that the American Rescue Plan Act also incentivizes Medicaid expansion for states, which is also critically important to ensure that pregnant people have access to the health care that they need. So for states that have yet to expand Medicaid, the American Rescue Plan Act would offer an addition of 90% of the federal matching funds that were available under the ACA for these states, and they'll now get a 5 percentage point increase in that regular federal matching rate for 2 years after the expansion takes into effect. So states really have more incentives, I think, than they have in a long time in order to expand coverage for everyone. And this is going to be particularly helpful for pregnant and birthing people. And last, I'll say, I mentioned earlier a little bit about what we're seeking in terms of this next reconciliation package. We're asking that the Momnibus be included, which Kichelle will talk about even more a little bit later in the panel. We want mandatory postpartum extension in the next package. And then we're also looking to ensure that coverage of doulas is also included under the Medicaid program as part of this next reconciliation package. So we have our hands in a lot of places when it comes to this maternal health work. But again, this is really the product of years of work, and we're in a really good place. As I said earlier, we have a supportive White House and administration, and for the most part, a supportive Congress that is ready to take on this issue. And so with that, I'm going to shift things a little bit. We've talked about the federal landscape when it comes to postpartum coverage extension in particular. And I want to shift and go to Breana and have Breana talk to us a little bit about what's happening at the state level. Breana, what is the status of coverage extensions across the United States, and what trends are you observing?
It's really been exciting to see the number of states that have introduced bills to extend coverage to a full year postpartum. And most of the bills that have passed have had bipartisan support, which is really great to see. This year alone, nearly 30 states introduced legislation, and several states actually passed those bills. However, there are still many states that have not passed legislation, and this is particularly concerning for those states that tend to have the highest maternal mortality and morbidity rates, yet the fewest maternal health protections in place. And so that's going to be states like Mississippi, Louisiana, and Kentucky. We've also seen states like Georgia and Texas make a good faith effort by extending to 6 months, but we really want to see that extension go to the full 12 months. And then the other point I want to make is that we should be cautious of states that are carving out specific populations that will be eligible for the extended benefits. For example, Missouri passed legislation that would extend coverage only for individuals needing substance use treatment. And similarly, other states only extended benefits for individuals diagnosed with mental health disorders. So while we acknowledge that these populations need extended coverage, so do the many other birthing people relying on Medicaid for healthcare coverage. So like I said, we've seen a lot of interest across the states, but I think the slow pace of states actually passing the bills and the varied criteria for eligibility, as well as the varied length of extended coverage, really underscores your point, Dr. Taylor, about the need for a federal mandate to extend coverage to a full year. I think it's important to point out that currently there are only 3 states that actually have approval from CMS to extend coverage. And of those 3 states, only one of those, Illinois, is for the full 12 months with no limits on eligibility. There are also 2 pending waivers right now waiting for CMS approval. And as I mentioned, there were 15 laws that were passed and enacted, but they have not yet submitted their application for approval from CMS. I also think it's important to point out, Dr. Taylor, you mentioned the American Rescue Plan Act and the state plan amendment provision within it. So far, only Indiana and Pennsylvania have announced that they will submit the state plan amendment through that provision. But once again, that won't be available until April of next year. So there is a lot of activity, but even with all of that momentum that I just mentioned of folks that actually have an implementation plan or are in the process of putting forth their waiver application, we're still going to be at a count of less than half of the states taking action on this issue. And that's assuming CMS approves all of the applications once they're submitted. So I think for this reason, it really is critical that we continue our federal advocacy for mandatory coverage, because I think the bottom line that hopefully we all agree on is that the state that you live in should not determine the level of maternity care coverage and the length of time that you have access to those benefits through Medicaid.
Yeah, that is totally right, Breana. And, as we've mentioned, postpartum coverage is a tool in the toolbox, right? We want a full 12 months of coverage for all pregnant and birthing people that qualify. At the same time, we're also working to address, some of these broader issues around like racism, the quality of care that birthing people receive. So while we're working to assure, or ensure access to postpartum care, eliminating racial and ethnic inequities in maternal health does require a complex, multifaceted approach to policy change, which we talked about earlier. So Breana, can you share more about, whether or not there are any other, policy opportunities that are happening at the state level that do sort of help to address this issue in a more comprehensive way?
Absolutely. There are so many opportunities, particularly at
Oh no, I think Breana may have frozen, but maybe we can
any response to that one, Kichelle? I don't know if you know.
I'm the state advocacy expert, but I will say that there are just kind of going back to the Momnibus. We've seen a few other states kind of almost copycat sort of the comprehensiveness of that legislation. So I know California has worked on their own version of the Momnibus, and North Carolina introduced their own pared down kind of version of the Momnibus as well. And so, we're seeing, I think, more and more states, really trying to tackle this issue in that really comprehensive manner. I think Massachusetts, I think their state legislature is working on some efforts, as well as in Ohio. I know those are two states in particular who reached out to our office after the launch of the Black Maternal Health Caucus, because they were they were interested in figuring out kind of how they could kind of develop policies that would help to target the maternal health disparities that we see in the Black community in particular.
You're absolutely right. The Momnibus has also, I think, helped to excite and galvanize, state stakeholders and advocates as well, to push for similar or model legislation within their own states that's similar to the Momnibus. And so let's stay on the topic of the Momnibus, and hopefully we will get Breana back soon. So Kichelle, why is the Momnibus considered the most comprehensive policy intervention to date for advancing maternal health equity and birth justice in the United States?
Well, Dr. Taylor, I think you touched on this a little bit earlier, but it is a 12 bill package. And over the years there have been kind of maternal health legislation that has been introduced, but sort of one bill here and there. And so what we really wanted to do was bring together and tackle kind of as many of these issues, in one fell swoop as possible. But also, I think this issue is incredibly complex. And so it requires a more complex and nuanced solution. And so, the bill was, when it first was conceptualized, I think we had 9 bills. And then when we reintroduced it just this recent Congress, we added 3 more bills on to really kind of address in a more timely manner some of the issues that we were seeing arising as a result of the COVID-19 pandemic. And so I want to really quickly try to give a quick overview of each of the bills. But the Momnibus, has, there's a bill that makes critical investments in social determinants of health, nutrition, transportation, access to care, the environment, climate. Those are all things that influence maternal health outcomes. And so that's a really, exciting bill that we're happy that we were able to incorporate into this legislation. A bill that provides funding for community-based organizations that are working kind of on the ground to improve maternal health outcomes and promote equity. And a lot of these community-based organizations tend to be, led by Black women. And so we really wanted to empower, the women who are in these communities to ensure that they're able to they know what's best in terms of caring for, the women and the birthing persons in their communities, right? And so comprehensively studying the unique maternal health risks facing pregnant and postpartum veterans and supporting VA maternity care coordination programs. There is legislation as part of the package to grow and diversify the perinatal workforce to ensure that every mom in America receives culturally congruent maternity care and support. So, that's your doulas, your lactation consultants, childbirth workers, ensuring that we are diversifying the individuals who are working in those spaces, improving data collection processes and quality measures, to better understand the causes of the maternal health crisis in the United States. And that will help us to inform the solutions to address it. Supporting moms with maternal mental health conditions and substance use disorders, improving maternal health care and support for incarcerated mothers and birthing persons, investing in digital tools like telehealth to improve maternal health outcomes in underserved areas, promoting innovative payment models to really incentivize high quality maternity care and continuity of insurance coverage from pregnancy through labor and delivery and up to that 1 year postpartum. Investing in federal programs to address the unique risks for and effects of COVID-19 during and after pregnancy, and to advance respectful maternity care in future public health settings and emergencies. Investing in community-based initiatives to reduce levels of and exposure to climate change-related risks for moms and babies. And lastly, promoting maternal vaccinations to protect the health and the safety of mothers and babies. And so, we've really tried to kind of wrap our arms around I think a number of interventions that we think would help to comprehensively address this crisis. But by no means, I think to Dr. Taylor's point, there are, of course, more ways that we could, I think, continue to improve upon the policy. But as of right now, this is kind of the most comprehensive sort of intervention that we are proposing and that the community, our community of advocates has really come behind and stood behind, as well as, with Senator Senator Harris, now Vice President Kamala Harris, who was such a pivotal leader in the Senate. We are really excited about hopefully the work and the advocacy that she will and has done, on the administration level as well. And we have Breana back. Welcome back.
Thanks. I just want to jump in. I know you all are discussing the Momnibus and just really grateful for all of the work that's happened at the federal level on the Momnibus, because I think it's opened the eyes of advocates and lawmakers alike at the state level about what's possible. And so since the introduction of the Momnibus Act of 2021, which was the second iteration of it, we've seen this wave of states with a real interest in making a state level Momnibus. And so I worked with several states of adapting the Momnibus to a kind of a state context and what was in state control to accomplish. And we saw several states introduce their own versions of the Momnibus, which is really exciting and gets to this question of how can we have like comprehensive change on this issue, which I think continues to be a struggle to make sure that our policymakers aren't saying, okay, well, we gave you this one thing, we gave you postpartum Medicaid extension, so then we're done with maternal health. No, we're not, because there are so many other things that have to be done. And before my internet betrayed me, what I was going to say was at the state level, there's like these three key bucket areas that if we approach or if we address issues around data quality, if we address issues around access to care, and that's not just postpartum Medicaid extension, it's access to doula services, it's access to midwifery care in community-based settings. And then also if we address racism, both within and beyond the healthcare system, and if we approach policy thinking about all of these three bucket areas, the data, the access to care, and the addressing racism, I really think that we can have real change and make vast improvements on maternal health outcomes and eliminate a lot of the inequities that we see. So thanks for letting me plug in there. Sorry.
Well, it was a perfect segue, actually.
Yes, absolutely. Thank you so much, Breana. And we kind of tried to get in there and cover a little bit, but it's awesome that you came back when you did, because your answer was much more comprehensive. Kichelle and I, since we are not, experts on state level policy, we sort of gave a very top line overview of what, states were doing. So glad to have you back. And that brings me to the next question. We're still on the Momnibus here. Kichelle, I don't know if you have anything to share about sort of the status of the Momnibus and, sort of next steps toward passage. I did talk about, this reconciliation process, Reconciliation 2.0 that Congress is currently undergoing now, and our efforts to get the Momnibus as a part of that next package. And, we still don't know how that's going to shake out. Negotiations are ongoing. So do you have anything else to share about the status of the Momnibus?
I think you covered it. I mean, I think in terms of sort of this different strategies that we were employing, we talked about moving the bill as a package. We talked about, moving it through the respective committees, each of the individual 12 bills, since, because the bill is so comprehensive, there are different committees of jurisdiction that the bills technically have to go through. There is a primary committee, which is the Committee on Energy and Commerce. But what we have seen actually is about 3 or 4 bills have now been marked up by the Committee on Energy and Commerce. And so we are seeing that incremental kind of progress happening, as a bill makes its way from, being drafted, to making its way to the floor. But the exciting thing that you said, you mentioned sort of our efforts to get it into the reconciliation package. That is, I think, really kind of our next big step. And we're hopeful to kind of see the progress we're making there. We have seen tremendous support from Senate and House leadership. Senator Schumer has come out publicly in support of the Momnibus. Speaker Pelosi and Majority Leader Steny Hoyer have come out publicly in support of the Momnibus. And we've seen kind of, unexpected partners, across, I think, the spectrum of Congress as well. And so, it is a pivotal year, I think, for us to get this across the finish line. And the last thing I'll add is, the administration, has proposed, I think, about $3 billion in funding for maternal health, interventions. I think that is still being mapped out as to what exactly they would like that funding to go towards. But we are seeing, I think, some really significant progress in that regard. So we're very excited about that.
Yeah, absolutely. And it looks like we're pretty much almost ready to go into the Q&A. Excuse me. But before I bring Allison back, I do want to take a moment to just give a brief sort of overview of reconciliation for some of our participants that may not know what we're talking about or what that process is. And basically, it's a special process where legislation goes through Congress, particularly starting in the Senate, originating in the Senate, where senators there's only a majority vote, a simple majority needed to get things through. And so, there aren't typically many opportunities in order to get legislation through in this way. And so if you think about the Momnibus, and we talked about some of the challenges in terms of, the caucus is bipartisan, but not every piece of legislation that's a part of the package is bipartisan, to be quite honest, in terms of, pieces that have both Republicans and Democrats on them. And so we see the reconciliation process as a really important opportunity for us to get the Momnibus through, particularly in Congress, where we only need a simple majority. And so with that, I am going to stop there and pass things over back to Allison, who will help us moderate the Q&A portion of the program.
Thank you all so much. It is such a joy to watch you and listen to you all speak. And I'm just so grateful for your discussion and letting us listen in and share it with you. So we do have some questions coming in through the Q&A portal. I'd encourage folks, now is the time, if you'd like to ask questions of our panelists, to please go to that Q&A tab for today's plenary session and feel free to start populating the questions that I'm sure have been springing to your mind during this conversation. So as folks are starting, I'll let people kind of think through their questions. I actually would love to ask a question of my own that we haven't, you guys haven't had time yet to discuss. And your conversation so far has focused a lot on legislation and Congress and state legislatures. I'm wondering if you could speak to opportunities for administrative action. Kichelle, you mentioned the $3 billion proposed investment from the Biden-Harris administration, but I know that there are other opportunities for state level action and advocacy as part of that. So Breana, I'm also looking at you in terms of thinking about state level administrative activity that's possible.
Absolutely. So there are a lot of opportunities. I think people, as you said, think only of the legislative piece, but I encourage all of you, if you're not already, engaging very closely with your departments of health. It may be separate agencies, it may be all in one, but you're both the public health side and also the Medicaid side. So starting with the public health side, I think one opportunity is with maternal mortality review committees. Even if you're not a member of the committee, I think it's important to be in conversation with your Department of Health about whether or not that committee is operating effectively. Are the right people at the table on that committee? Is there sufficient community voice? Is there a good balance of power with clinical and non-clinical folks? Are the reports that they're putting out being disseminated broadly into the community and in a timely manner? So if the answer to any of those questions is no, there's opportunities for you to engage on your MMRC and Department of Health there. I think another opportunity is with your state's Perinatal Quality Collaborative. Great opportunities from a quality improvement perspective. But I think once again, those PQCs can be really clinically focused and miss out on incorporating the community voice. And then you end up missing the mark of having as great of reach and impact as you could with those efforts when the community isn't engaged in those conversations. We talked a lot about postpartum Medicaid extension today, and I think what we really need to pay attention to as states begin implementing the extended coverage and as these waivers are approved is making sure that our state Medicaid agencies are implementing the programs, this extended coverage in the way that it was intended. I'm still very frustrated with the circumstances of the pandemic right now, where there was a disenrollment freeze of Medicaid. So really anyone that was on Medicaid during the pandemic already had extended coverage, but guess what? They didn't know it. And providers didn't know it. And providers were scared to provide services because they really didn't understand, how this was working. And I think that our Medicaid agencies failed our birthing people, our providers, and everyone involved of really maximizing that benefit that was available to them during the pandemic. And so I think we need to make sure that we don't repeat that once states extend the coverage to the full year, because we've been fighting for this for a while. So let's hold them accountable to actually do the right thing with this. And then finally, I just want to encourage you all to talk to your state departments of health about data. So, make sure they're putting it out. I think sometimes they think that we're not looking at the data, but we are, and we need the data to advocate for these issues. So if there's something that you'd like to know that they're not putting it out there, ask them for it. So I think there are a lot of opportunities to do some administrative advocacy that really help us with just program implementation and things that don't require legislation, but it also sets us up when we do need to go to the state capitol and advocate for these issues.
Absolutely. That was perfect. I don't think there's anything more that I can add to that. That was excellent.
I had something to briefly add. I mean, part of the question is also about what the administration can do. The administration has already done a lot, and I'm not going to go over everything, but just a few things, because I want to give the audience a chance to ask questions too. President Biden issued the first ever proclamation to recognize Black Maternal Health Week, which was really amazing. Breana talked about the approval of the Section 1115 waivers. There has also been historic investments in things like addressing implicit bias, rural maternity care, and MMRCs. I think at this point, one really important thing that this administration can do is support what we're asking Congress to do as part of the reconciliation package. And so that's, supporting the Momnibus, mandatory postpartum coverage extension to a year, and doula coverage under the Medicaid program. So I just wanted to flag that.
Thank you all so much. And thinking about the postpartum Medicaid period, a question from the audience from Colleen in New Mexico. She's asking about if there are recommended postpartum services for state Medicaid to cover. And if you guys have suggestions for her, or maybe organizations that she might look to for suggestions about what state Medicaid should cover in that postpartum period. And also thinking about, in addition to OB offices, other providers, nutrition, behavioral health, physical therapy. Colleen is saying that New Mexico's in a position where they're looking to expand coverage under Medicaid in the postpartum period, and are looking for advice.
I mean, I can start. I'm sure Breana may have something to add here. I mean, look, based off of the conversations that TCF and the Commonwealth Fund had with moms, that spoke candidly about the challenges that they had experienced when they lost their coverage. Some of the biggies were, having that, a care coordinator, which is a part of what is covered under Medicaid, particularly for those that are high need, that need to see several healthcare providers for a host of issues. I think that's critically important. Family planning, which we know is mandated to be covered under the Medicaid program, is a biggie, and a big reason why we need to make sure that coverage continues on, particularly for moms that want to delay any future pregnancies. Access to mental health care and substance use disorder treatment is important. But at the end of the day, we want the full spectrum of care that is covered under traditional Medicaid to also be covered, under the extension. And so I think we get into some challenges, and Breana spoke candidly about this, where states are sort of cherry picking the services that they will offer women and birthing people if that coverage is extended. We want comprehensive coverage. We want women to have their preventive care. We want them to have their family planning. We want them to have, their mental health services and support. And so any sort of state level advocacy that you all are doing, and thank you so much for doing that, we ask that you ask for the comprehensive suite of services. And then I'll pass things over to Breana, who I'm sure has more to add to this.
No, you You summed it up perfectly. There are states that already do that even before the extension to 12 months. Mm-hmm. So I think it's great to look at how other states have crafted their programs to provide the full scope of services. But that is, I think, the recommendation.
One more follow-up to that, Allison, too, is that I think there was also a question about like the providers. And so absolutely right. We want, the medical care is key, and we want to make sure that everyone has access to that. But also, a big part of this is making sure that, in terms of that care coordination, that families are also able to access their, social services and supports that they need that are a broader part of like the network of services for families, as well as mental health care, having access to community-based providers, those that are, working on the front lines to meet families where they are and serve them. That's critically important. And then also too, I think another thing that we've talked about that I think has been a theme in the conversation today is access to doulas and midwives as well. And so, there could be a whole host of other, I think, providers we could mention. It's really particular to the needs of that woman and her family. But those are just some of the others that also need to be looped in and ensure that there is coverage and support there.
Thank you. So I want to squeeze in one more audience question before I ask you a final question. So a couple of questions have come in about commercial payers and their role in this space, commercial healthcare payers, and thinking about what are opportunities there, thoughts on alternative payment models related to the postpartum period. And there was a question about participating in value-based payment and implementing quality improvement measures. So I don't know if any of you have responses about the role of private payers in this space and priorities there.
I mean, I can start off and say, private payers are starting to, I think, engage on this issue. They are starting to think through how they can be better and more generous about covering things like doula care and ensuring that midwives are also covered through their plans. I think another key piece too, and we could have probably had a whole separate panel on this, is I think this broader effort to think through racial equity in the context of healthcare. And I've seen some payers starting to even train not only their internal staff, but also the providers that they work with, and helping to ensure that they're thinking about racial equity in the context of healthcare in a way that ensures quality of care. I would love to see more conversation about systemic racism and how it manifests in healthcare, not only in the context of maternal health, but also just broader healthcare experiences, particularly for the Black community. So they're getting there, but I mean, I think more could be done. I think we need to continue to stay in conversation with them. But again, keeping in mind that, we don't necessarily have the tools to regulate them as we do with publicly funded and financed insurance, which is part of the reason why we do focus so heavily on programs like Medicaid and the Affordable Care Act and others. But private insurers definitely have a role to play. And then also just a nod to the person who mentioned, value-based care, which is something that I advocated for in the context of the TCF report, where we looked at postpartum coverage extension and the need to address some of the issues around quality care, which is essential to this comprehensive approach to the maternal health issue, which has been a theme in the conversation today.
Yeah, and I just want to also chime in. I think, Dr. Taylor, you hit it right on the head that, payers are starting to, I think, engage a bit more and figure out how they can best plug in and incentivize, better behavior as well from hospital systems and physicians. I'm going to call out one in particular because they made I think, a really big public commitment earlier this year. But Blue Cross Blue Shield came out and said that they have made a commitment across the board to try to reduce maternal mortality by 50% over the next 5 years. And so, it's certainly an issue that they are making a priority. And I think a number of their different plans across the United States, each of the plans do different things. And so, some plans are a bit more hands-on than others in terms of providing the supports that, new mothers need. And so, whether it's meal services, whether it's, finding different ways to kind of make sure that new parents and new mothers have, coverage for certain services. That's been really critical. And then also to the nod that in the question about innovative payment models, in the Momnibus, we really we encourage the Center for Medicaid and Medicare Innovation, CMMI, that is housed under CMS. We encourage them to develop, I think, some innovative payment models around, helping to reduce maternal health disparities and mortality. And so that's definitely an avenue that we're hopeful will be pursued greater.
So I'm going to squeeze in one final question, and I'd love for each of you to address it, but fairly quickly, because we're running a bit short on time, but I want to make sure to send off our audience members with some advice. And so I'm wondering if each of you could share, if folks want to be engaged and support the policy work that you've talked about today, how can they get involved? And there was a request, so there was a question from the audience about this, and the specific request was for something small and tangible. Whoever wants to jump in first, please go right ahead.
I can go first. I think that's easy. Reach out to your representatives in Congress, both in the House and Senate. And I want to stress the Senate because we're in this critical moment as they're thinking through this reconciliation deal, and add to include the Black maternal health Momnibus in reconciliation, as well as mandatory postpartum coverage to at least 1 year.
Yep, I'll piggyback on that and just say, if you're not able to get in touch with your DC office or the DC office, reach out to your local district office because, they're often a lot more accessible and they may even sit down with you, have a meeting, and then that information makes its way back up to DC. And so, just make sure we can drop links in the chat and wherever you need, but there are a lot of ways to kind of plug in and really influence, in particular, your federal policymakers. So don't be afraid to reach out.
And I'm going to shift and say, don't wait for legislative change. So think about what you can do, what's within your scope of control at your academic institutions, your hospitals, especially you've heard us talk a lot about the impacts of racism, discrimination, and bias on the delivery of services and the quality of care. Think about what you can do now in your institutions to change that. Consider hiring or consulting with Black leaders in your communities to really look at your policies and see what can change. And then, because I do work on legislative policy, if you are able to engage in legislative action and you're interested in advancing human rights, reproductive justice, and birth justice in your states, reach out to me directly because then we can definitely talk about some examples of state policy that you can advance.
Breana, Kichelle, Dr. Taylor, thank you so much. This was a joy. I am going to shift us over and invite Amy Ushry to join us. And she will close out this panel for us and talk about what's coming next as part of the symposium.
Great. Thank you so much to Allison and to all of the panelists, Dr. Taylor, Breana Lipscomb, and Kichelle Webster. That was absolutely tremendous. So thank you so much. I do have a few transition remarks. Again, my name is Amy Ushry, and I'm here on behalf of the American College of Obstetricians and Gynecologists, or ACOG. ACOG is the premier professional membership organization for obstetricians and gynecologists, and ACOG is also the recipient and the leading organization of the Alliance for Innovation on Maternal Health, or AIM program, which is a cooperative agreement with the U.S. Department of Health and Human Services, Health Resources and Services Administration's Maternal and Child Health Bureau. We're also a proud partner in the Maternal Health Learning and Innovation Center. So we're now going to take a brief break. And at 1:45 p.m., you can join one of the many concurrent sessions available to pick from. There are 2 opportunities to join concurrent sessions today. There is one schedule change to note, the session called Ritualizing Change, Turning the Tide on Maternal Mortality Through Community Healing, Design for Equity, Ciphers, and Primary Interventions is no longer available. We do hope to have that session in future events. Please be sure to scroll down on the concurrent session list because there are many great sessions available, and you want to be sure that you see all of the options. I do want to remind everyone to visit the survey section of the Symposium app to complete the evaluation before you leave the event today. And don't forget to rejoin the main stage at 4:15 to hear from our final speaker, Sonia Renee Taylor. Thank you so much, and we'll see you back in the concurrent sessions at 1:45. Thank you.